Top Bed Talk.
Good afternoon, everyone. This session is our Perioperative Quality Initiative session. You'll hear more about what the Perioperative Quality Initiative is during the course of the session. Next, we'll go through POQI II, so my co-chair of the EBPOM meeting, Monty Mythen, will take us through. Thanks very much.
So, POQI II, so you've seen this photograph already. Stony Brook, December 2016. And I think you must be doing quite well. Well, by this stage, we were accepted into Anaesthesia and Analgesia and immediately had 3 accompanying editorials. And some of you will recognise, probably not from the size of the font there, but I'll read them to you. The 3 areas, which is patient-reported outcomes, the editorialists were Lee Fleischer and Cliff Coe. Standardising the classification of impaired gastric function, we got Elizabeth Wick and Chris Wu. And then we have the perioperative nutrition, our high-impact, low-risk, low-cost intervention. We've got Mike Scott and Robert Martindale doing that one. So we think we were starting to get things even righter at that stage. Does that word work? So here's very quickly through, and I know we keep saying that, but we've got a lot to get through here today, and there's particular areas we want to highlight for more discussion. So I'm not a nutrition expert, but I'm an enthusiast. And here we can see the output from the perioperative nutrition POQI. Those are the 4 infographics. Walking them through you in a little bit more detail, we were convinced that 2 out of 3 patients coming for surgery are malnourished. There's 3 times greater the risk if you're malnourished of having a poor outcome and more likely to die, 5 times more likely to die, and that 1 in 5 patients have formal nutrition and screening, only 1 in 5 in the USA at the moment. But 3 out of 4 surgeons believe it makes a difference. And we were convinced that the financial benefit was that for every $1 spent, it saved $52. But only 1 out of 5, and this is very US tilted, patients receive any preoperative nutrition intervention. I would believe that probably resonates with many of us, but we can come back to that in discussion. The POQI 6 are nice and simple. Pre-op, post-op nutrition screening is essential. Protein is more important than calories. Stop feeding late pre-op, restart early post-op. Consider all nutrition supplements for all, oral, before enteral, before parenteral, and nutrition management as a team game. The PONS score was a new output from this meeting, very much driven by Professor Paul Wishmeyer from Duke University Medical Center and colleagues. Nice and simple and pragmatic, and we've heard it presented a number of times at this meeting, so particularly in some of the abstract presentations and on day 1. Step 1 relates to BMI. Step 2 is about unplanned weight loss. Step 3 is whether you think that the diet has decreased dramatically leading up to evaluation. If any of them are yes, the only controversial test that was added in was an evaluation of albumin, but it was thought to be worth the time and the effort. And that gives you your PONS screening tool. Then you divide your patients into the lower risk and the much higher risk. So for the low nutrition risk, and this one goes round 1, 2, 3, 4, 5, scheduled for surgery, do your assessment, do the albumin. If it's below the threshold, you're deemed to be low risk, which is the majority of patients in the UK, for example. Then the controversial elements that the experts strongly recommended and we backed as being a reasonable recommendation was the use of oral immunonutrition for 5 days preoperative and 7 days postoperatively, and we might come back to that in discussion. I'm not going to go through all of the detail of the high risk one. You can read through it yourself or look separately online. It's basically saying, as we might anticipate, that this is a much more detailed, iterative process which requires repeated evaluation and repeated targeted intervention until the goal is achieved of having as adequately supplemented patient as possible prior to proceeding to surgery. So if one has time, it is important to wait if that is possible. We know time is not always there, but we can do our best under certain circumstances like cancer surgery, for example. I'm going to spend a little bit longer on this one, which is the middle section, because I work mainly in the surgical, I did until recently, surgical intensive care unit, and I found this to be very, very practical and useful on a weekly basis in that environment. It's about postoperative GI tract dysfunction. This in particular I found very useful for the residents and the nurses at the bedside, which is the iFeed scoring system. Now, it's easy when the patient is scoring zeros across the board here. In other words, they're tolerating an oral diet, they're not feeling nauseated, they don't have any emesis, they have no signs or symptoms, and they're fine for the first 24 hours. So that's the drinking, eating patient. The grey zone is much more common, you know, the limited tolerance, they're less responsive to treatment, they might have had a little vomit and so on, through to the one that's much easier to spot, which is they're now completely intolerant, they're resistant to treatment, and so on. And that lasts for more than 72 hours, for example. We decided to drop the term ileus, which is a recurring theme in the literature, because it means so many different things to different people. And we settled on, based on prior art, postoperative GI intolerance and postoperative GI dysfunction. So POGI and POGD. So normal is what we hope the majority of our patients will be postoperatively. And in enhanced recovery program, they're early mobilized and given the opportunity to drink and eat in almost every circumstance straight away without the presence of a nasogastric tube. And you hope that when that happens, they continue to drink and eat without getting nausea, bloating, etc., etc. If that's not quite working, you get to the intolerance level, which is the 3 to 5, and then the GI tract dysfunction, which would traditionally have been coded as an ileus or ileus. They then go on to say, well, here's a traffic light system as to what to do. Well, if you're normal, your clinical presentation is you're drinking and eating normally, you carry on allowing them to drink and eat and you proceed down your enhanced recovery pathway. And you now hope that is the vast majority of your patients. In the grey zone or the amber zone we put here, the yellow zone, if they've got difficulty with the oral intake, they're belching, they've got nausea, etc., you can try and modify your antiemetics, but really it's actually backing off on intake and addressing all of the other factors that might be contributing. So it might be that they need a little bit of loosening of the bowels, they might need to stand up more often. You know, our surgical colleagues who do this for a living are the best to advise on this, and they were the lead authors on this. The final one is, as enhanced recovery includes not having the routine placement of a nasogastric tube, the risk is that people are now fearful of putting them in when they're needed. So what we had was a clear guidance there that once they're intolerant and they've got a clear what used to be a classical ileus, in other words, they've got that intolerance of food, they're nauseated, it's not recovering, the nasogastric tube is an excellent primary intervention. And myself, who works in this environment as an anaesthetist intensivist, and my colorectal surgical colleagues, we were all laughing about the fact that this is the only time that a patient says thank you for a nasogastric tube. You know it's the right intervention when they go, oh, that feels better, if you see what I mean. So that's the way you've worked it out. Now, to emphasise on the grading system that we use, the language that goes with it, the difference between strongly recommended and recommended, you can see down the right-hand side, it's unusual to get a strongly recommended. With the bar height that's set, because this is a balance between evidence and grade and opinion, you actually end up with very few things that are strongly recommended. A few things that are consider, which is a lighter level of recommendation, and the only 3 strongly recommended we had, remembering this is in the context of enhanced recovery for elective colorectal surgery, was if you want to reduce postoperative GI tract dysfunction, use enhanced recovery protocols. Do not routinely use prophylactic nasogastric tubes, and allow immediate postoperative eating and drinking after colorectal surgery. Now, today, that doesn't seem surprising to us at all, but take yourself back 15 years, and for many people, they were just crazy recommendations. The others, a lot more debate starts to creep in particular the use of, for example, alvimipam, which is a peripheral mu opioid antagonist. It's not available in some places. But when we reviewed this in the setting of predominantly US practice, the evidence that was clear as presented to us to make a recommendation that it should be used under certain circumstances. The others I'll leave you to consume for a moment. I want to highlight things, for example, the maintenance of euvolemia. You know, there was for some people a bit of a discussion about why is that relevant to postoperative GI tract dysfunction? Well, you know, edema, dehydration, under resuscitation, etc., all contribute. So the final one, which I'm going to touch on very briefly, is the importance of patient-reported outcomes in enhanced recovery pathway. So this is more of a signposting exercise, so I think is an excellent account and summary of the challenges of patient-reported outcomes. Some nice infographics in there again. I'll highlight a few of them. This has become quite familiar, from baseline deterioration rehabilitation to new baseline. The idea that the classical care before enhanced recovery, there was a deterioration and possibly a recovery not to where the patient started from. And to truly evaluate that, you have to look at patient-reported outcomes that go out quite a long time. And the important thing you would hope is that recovery would represent return to baseline, or ideally greater, because that's why you went for the surgical procedure. This is an eye chart, but it basically recognises, if you want this as a reference article, the very different components of some of the well-recognised scores like the EORTC-QLQ, the EQ5D, and so on. Many of you have heard of the QOR, the SF36. There is in there a simplified Wilson-Cleary classification of patient outcomes. I'm now like a weather reporter. I don't know what I'm really talking about here. But it represents the various different inputs, whether they be psychological, social and economic, social and psychological, and we've already heard some reports on Monday about the importance of all of those components that contribute to symptom status, functional status, general health perception, and feed into overall quality of life. Then there's a couple of charts at the end that give you a schema and then some recommendations at the bottom for which PROM scoring systems one might choose for baseline, inpatient, early post-op discharge and late post-op discharge. And you can see here it's quite a list that one can choose from, because the evidence base is far from clear as to what one could strongly recommend, as opposed to saying this is an ambition that we have and it seems worthy to continue to pursue it. And then there's a suggestion, a more simplified version, based on all the available we had to review, as what one we thought should consider first as a preoperative inpatient, post-discharge day 30, post-discharge day 90 alternatives. Thank you for listening.
Thank you very much, Monty. The final presentation, which is POQI III, which focused on blood pressure, is from Andy Shaw. You've heard from Andy already this afternoon in the great fluid debate. Thanks very much.
Thank you very much, Mike. And thank you very much, Monty. POQI III occurred right here, just down the road, outside, not outside the Montague, actually inside the Montague. And I think as I hope you're getting the theme that we're actually the five of us are very, very proud of the outputs that these conferences produce. And in fact, in May 2019, we were the cover picture in the British Journal, which I remain extremely proud of. Some disclosures, none of these are relevant for me personally. Some of these companies have supported POQI, for which we are grateful. Quick comment about that. All of the discussion, all of the writing is made by the faculty. There is no commercial input at all, and I think it's important to emphasise that. We've been criticised a little bit for taking money from industry to do this work, but it's important to point out that that really pays basically for travel, and that's it. The actual content and the discussion comes from the people. Thank you very much to the EBPOM team. I've had a great couple of weeks here. On the right there, that's Caro Garcia, and she's my favourite female tennis player until she started putting all the Brits out, in which case there's me cheering for her and the rest of Court 1 not. Anyway, we've had a great couple of weeks here, so thank you for the invitation. You've seen this. These are the five of us who had this idea and have worked hard to promulgate it over the last 5 to 6 years, so I won't dwell on that. I will say that since this work came out, there's been a lot of other, notably observational work done in this space, and the field, we've kind of, I think, opened up a little bit of a hornet's nest here, because, and we'll talk about this in the discussion, there's clear risks involved, and just by highlighting them, people try and fix them on their own, and that might then lead to further problems, and we'll talk a little about that. I'm referring to hypotension and the increased use of vasopressors in the operating room. POQI III produced 4 manuscripts. One was a succinct description of the physiology of blood pressure. There was a pre-op manuscript, intra-op and post-op. These are the altmetric reports. All 4 of these are in the top 5% of all research output in all disciplines, which is something we're very proud of. And those of you that follow how to rate the literature will have noticed the incredible effect of COVID on impact factor in journals very recently. And so we start to think about other ways to measure impact, measure contributions. And you'll see here that what are we as anesthesiologists and anaesthetists interested in? Physiology and the OR. And it's no surprise that those are the 2 highest attention scores of these 4 papers. So a little bit of background, then I'll briefly summarise the outputs of the 3 papers. In terms of defining the problem, there still is no accepted single definition. There's a little bit like acute kidney injury. There's 100 and something papers, many definitions, and so how do we actually know what the true incidence is? Except for we know it's common, right? So the commonest definition has been a systolic blood pressure more than 20% reduced from baseline. Well, how do you define baseline? Well, we'll talk about that. And any systolic under 18 millimeters of mercury. Most people think they know what hypotension is, but in terms of actually characterizing it so you can study it, it's actually very difficult. What is the incidence? Well, we know it's common. This paper in the American literature was based on a study of 15,000 patients, and you can see that the laxer you are with your definition, obviously, the more common the problem is. 93% of patients have at least one episode, 93%, so it's almost ubiquitous, of more than 20% decrease from baseline. And 40% of patients, so almost 1 in 2, have a systolic under 80. So we don't look that great, really. And we worried about this amongst the 5 of us and thought we ought to have a meeting to get a little bit more traction around this space, to try and define a research agenda, to try and shake the tree a little bit. And so the preoperative blood pressure group published this paper led by Rob Sanders. And the gist of this group was, well, how can we define what the baseline is? And it turns out that the pre-induction map is actually a little bit higher than it was during the preoperative evaluation. Call it scrub hypertension, white coat hypertension, whatever you like. But you can see here on this graph on the right, the mean of the pre-induction and pre-op actually is a little bit higher than it is pre-op. So what that means is, on the average, the blood pressure at induction is a little bit higher than it was during preoperative evaluation. Well, what does that mean? Well, it means that perhaps the relative hypotension might be exaggerated, whereas an absolute number might be more relevant. Is that true or not? We decided that ambulatory blood pressure measurement is probably the best way to try and establish what the baseline blood pressure is. Well, what's an ambulatory blood pressure? Who walks around with a cuff on their arm? Currently, not many people, but in the future with wearables, maybe all of us will. So back in the day when we were talking about this, an ambulatory value we thought would be a daytime average from an automated device at repeated intervals while you do your thing. So not just sitting, lying on a chaise longue or whatever in the clinic, but doing your normal thing, an average blood pressure. And if you haven't got that, then a clinic blood pressure or an office blood pressure would be best, ideally within 30 days, to try and get at this effect that the blood pressure pre-induction isn't where the patient usually lives. And although extremes of blood pressure may be associated with increased perioperative risk, surprisingly, we were unable to identify a specific blood pressure threshold upon which you should decide a go, no go. So that's important. You would think with all of the literature that's been published, all of the common sense around, when do you cancel, when don't you? And of course, it's not just a straightforward blood pressure. That's a very dynamic process that has a lot of other factors involved. We couldn't find a study that could clearly identify a threshold of blood pressure either on the low side or the high side, but we were able to ascertain that it is a J. There is an optimum number. It's just we can't put our finger on it, in large part because of a failure of a consensus of definition, a failure to understand when the baseline is. There's also insufficient evidence to support bringing a high blood pressure down unless there's obvious acute pathology in terms of hypertension. So there's a lot of work to do in this space still. Something as simple as blood pressure. We produced this infographic for this paper, which I still think is quite helpful, and it displays the timescale on the x-axis from pre-op to induction. And blood pressure, this is low to high on the left-hand side. So there isn't any evidence to lower a high blood pressure immediately pre-op. We do know that preoperative low blood pressure increases risk. And we know that as far as thiazides and calcium channel blockers, there isn't any evidence to stop them. A lot of people do, though. Loop diuretics, should you continue or should you hold? That probably is a much more nuanced decision than something that can fit the middle part of an infographic. And beta blockers in particular were very contentious. There's evidence to stop them, there's evidence to not stop them. And so we thought we would recommend to, when the indication is congestive heart failure or a previous MI, continue it. Otherwise, don't. And don't start preoperatively just for risk reduction. We learned from the POIS papers that's not the right thing to do. The intraoperative group was extraordinarily vocal, which is a kind of polite way of saying they almost came to blows. I won't say who the protagonists were, because some of them are in the room. In fact, Josh, I think, just walked in. I think he will remember this with aplomb and is sworn to secrecy. Anyway, this was the gist of the question. Does intraoperative hypotension matter? Seems such an easy question with an obvious yes, but actually quite hard to pin down, because if you say, well, yes, it does, well, then you say, well, when does it matter? How much does it matter? What do I have to do? Does it matter what I have to do about it? And the answer to all of those questions is probably yes. Now, since these papers were published, there's been a lot more work done in this space, and I've been involved in some of that work. And it is becoming clear that, yes, intraoperative blood pressure really does matter. At the time these papers were published, there was evidence that a MAP below 60 to 70 is associated with myocardial injury after non-cardiac surgery, AKI, and death. And a systolic blood pressure below 100 is also associated with adverse outcomes, notably MINS and death. And the severity appears to be dose-dependent. In other words, the lower for the longer, the worse it is. But the problem is, even now, it's still a qualitative discussion. The lower for the longer, the worse. Well, does that mean 15 minutes below 65? And is that the same as 5 minutes below 55? All of this stuff matters because there is stuff we can do about it. We just don't know what to do. So the old adage from our cardiology consultant, avoid hypoxemia and hypotension, turns out to be qualitatively correct. But we need to know what to do about it. We still don't know what the exact situation is with pre-op hypertension, but we suspect that the threshold at which the problem begins is probably a little bit higher. Here's a couple of the infographics we chose. This is the lowest map on the left-hand side, panel A, and the percentage decrease below a baseline map, panel B. And you can see this is for MINS. Like I said, the lower it is, the higher the incidence of MINS, both cumulative 10 minutes and 3 minutes. Same for death. This is the time-weighted average of mean arterial pressure. In other words, the integral of time below a certain level. This is mortality, 30-day mortality. And you can see with a time-weighted average below 60, you're knocking on the 1 in 100 for all comers. So it's a big deal, this. And this is to illustrate the concept of systolic instability, which is the mean duration your systolic drifts under 95 on the left and 130 on the right, somewhat arbitrarily represented to demonstrate hypertension. And this is probably the nub of this particular paper. When you identify a problem and you persuade people it's a real problem, we were talking about this in the fluid debate a little bit, responsible caregivers try and avoid it. And they try and avoid it in the way they know best. So what's by far the easiest way to get the blood pressure up in the operating room is give a quick push of neosynephrine or phenylephrine or norepinephrine or whatever your vasopressor of choice is. We were very concerned that people would do that, and as it subsequently turns out, they have done that. And so we have a responsibility to continue this dialogue into the post-POQI space and figure out some interventional work. The statement was there are at least strong theoretical concerns about using pure alpha agonists just to increase the blood pressure because of the problem of inevitable compromise of tissue perfusion, which is the real problem. And I still think that's an unsolved issue. The post-op group produced a couple of, I still think, quite useful infographics, which really get to the point of what to do. It's fine when no one's on vasopressors or IV antihypertensives and the blood pressure's normal and the heart rate's less than 100. Obviously, they can go to the ward. But what about when it's not? How much do you have to stand there in the PACU and keep on giving treatment until they have to go to the ICU or a step-down unit? So that's what the infographic on the left is aiming to do. And on the right, we try and provide a rational approach to measuring and assessing deranged blood pressure, both low and high. So in step 3 here, for example, you can see, does a passive leg raise test increase the patient's blood pressure or not? Are there other obvious causes of hypertension? And so this is a way to try and codify in a way that we were hoping people could print and put on the back of their name badge. In terms of the future research agenda, are there organ-specific thresholds for autoregulation? Are they different? There's been quite a bit of work done in the brain. Chuck Hoag's group, now at, originally at Hopkins and now at Northwestern, has started to work at that. Is that the same for other organs? And if it is, then are those thresholds changeable? Which part of blood pressure is really the one to measure? Is it the systolic? Is it the MAP? Is it the diastolic? Does it matter how you think about the MAP, if it's calculated or measured? Is it the pulse pressure? Is it all or none or some of the above? We still actually don't know that. Does the way you measure blood pressure, does the way you monitor both the blood pressure and treatments matter? Probably, but again, we don't really know. And one of the themes that you're probably picking up from POQI is, well, we don't know. And that's okay, because you can't start to answer a question until you've at least addressed it, thought about it, and articulated a little bit. If we have technology available to specifically dial in a blood pressure, a little bit like we use insulin and glucose to clamp the blood glucose around a value of, say, 5 to 7. Well, we could do that with a mixture of a vasopressor and a vasodilator if we had a continuous blood pressure readout. Is that a good thing or a bad thing? We don't really know. And if it is a good thing, does it matter what the intravascular volume status is? Probably, but again, we don't have any hard and fast rules. And perhaps the most important thing is, if the blood pressure is low, does it matter what we do? And is it as simple as getting the blood pressure up in the best way you think, or should it prompt a further exploration, further thought about the cause? That's all I have. Thanks very much.
Top Med Talk. Thanks for downloading Top Med Talk. Don't forget to subscribe via your podcatcher. Don't forget to check us out on social media. We're on Twitter, Facebook, LinkedIn, and YouTube. And also, don't forget, Top Med Talk is the broadcasting arm of EBPOM, Evidence Based Perioperative Medicine. We'd love you to find out more about that. If you check out ebpom.org, you can find low prices on some of the conferences we're organising around the world. Many of them are virtual and don't even involve you leaving your own home. Check out ebpom.org now.